Hello, everybody. Good morning, and in some cases, good afternoon to all of you. Thank you for joining us today for Precisionary Scientific Webinar. We're going to be hosting Dr. Farida Ahangari from Yale for her talk on pulmonary fibrosis using PCLS. Before I introduce our wonderful speaker today, I just wanted to say if you are in the audience, please know you can use the chat during the talk to ask questions, comments, raise your hand. And towards the end, I will also moderate a Q&A session, and you're more than welcome to unmute yourself, and I'll let you into the admin room for you to ask your question and show your video if you like directly with Dr. Ahangari. So with that, it is my honor to introduce our guest speaker today, Dr. Farida Ahangari. She's an assistant professor of medicine at the Yale School of Medicine, specifically with the section of pulmonary critical care and sleep medicine. In addition to her faculty role, she serves as the director of targeted drug delivery and therapeutic modeling. Her work is at the forefront of advancing novel therapies for fibrotic lung diseases. One of the hallmarks of her research is the use of precision cut lung slices, or PCLS, to evaluate candidate therapies in physiological relevant human-centric settings, which is really important nowadays because there's a huge NIH shift towards working with human tissue and models and away from animal models. So today she'll be sharing her insights on how we can bridge the gap between bench research and clinical application. So please join me in giving a warm welcome to Dr. Farida Ahangari. Thank you so much.
Thank you so much, Abby. Thank you for the, Thank you for the nice introduction and for inviting me to speak here. So I'm so glad to be here. So today I'm going to talk about a preclinical roadmap for advancing new therapies for pulmonary fibrosis. Pulmonary fibrosis is a part of a group of pulmonary disorders called interstitial lung disease, or ILD. ILD characterized by inflammation and/or fibrosis of the lung parenchyma, often progress to end-stage respiratory failure. We classified ILD in different categories: autoimmune ILD, idiopathic interstitial pneumonia, included IPF and other subcategories, hypersensitivity pneumonitis, drug-induced ILD, infectious-related, or unclassifiable. Although different types of ILD have distinct pathophysiology, clinical manifestations, and prognosis, all forms of ILD can cause irreversible pulmonary fibrosis. Today, I'm focusing mostly on idiopathic pulmonary fibrosis, or IPF. IPF is a debilitating and fatal lung disease of unknown origin. Approximately 3 million people suffer from this disease around the world. And in the United States today, over 250,000 cases exist, 50,000 new cases each year, and almost 40,000 people die from this disease per year. The median survival after diagnosis is only 2 to 3 years. We have 3 FDA-approved drugs since 2014. 2 of them started 2014, and 1 of them added just recently. But 3 of them, they slow disease progression, but do not cure IPF or reverse fibrosis. Lung transplantation remains the only curative option for this patient. There is a huge unmet need for the development of more effective and safe therapies, and our team actively working to find new targets and develop new drugs for this disease. Before starting, I would like to give you the very brief overview of the process of drug development pipeline in lung disease, which is very common with many other organ and many other diseases. First, we start in the lab as a discovery phase. We identify the target, pinpointing molecular and cellular targets relevant to the lung disease. Then we will move to target validation using preclinical model, mostly in vitro cell culture system, or in vivo using animal models. After identification of our lead compound, we'll move to preclinical development. We will perform mechanistic studies, understanding drug action, toxicity, and pharmacokinetics of the drug, and move toward lead compound optimization, perform more advanced safety and efficacy studies in lung disease model. After progressing from all these stages, if everything goes well, we'll move toward clinical development. Clinical trial will start. Phase 1, safety. Testing safety in a small human cohort. Phase 2, efficacy. Evaluating drug efficacy and dosing in lung disease patients. Phase 3, large-scale testing, confirming efficacy and monitoring the side effects. After all these lengthy process, if everything works well, we will finalize the drug review and make the package to present for FDA approval. Known facts in this process. This lengthy process will take at least 10 to 15 years for each new drug to be approved for clinical use. I even don't mention about the funding and money that we have to invest in this process. But we know that 9 out of 10 drug candidates after have entered clinical studies would fail during one of the phases of the clinical trials and drug approval. Why? Why they fail? Most of the time, they show lack of clinical efficacy when it goes to human. Some of them, they have unmanageable toxicity, sometimes poor drug-like properties, and sometimes a lack of commercial needs and poor strategic planning happening. But the most dominant reason is lack of clinical efficacy when it goes to human. But why? What is the key reason for failure in IPF clinical trial? First, we know that IPF has a very complex disease biology. It requires specialized models and biomarkers for effective development. There is a wide range of heterogeneity among patients. The disease can progress differently in patients, leading to varied responses to therapies. Some drugs have safety concerns. So when it goes to human, we will see side effects like liver toxicity and other things. But I want to highlight 2 important reasons that happens very often. They show lack of predictive preclinical models. Animal models and in vitro system that we usually use in the lab to get to that stage of the research, they often fail to replicate when it goes to human disease. And second, lack of significant efficacy in human. Many drug candidates failed to slow the progression of the disease or improve lung function significantly compared to placebo or standard therapies. What should we do? I want to highlight here 2, at least I want to bring 2 concepts that maybe we can change it to solve these failure in IPF clinical trial. First, we have to find better preclinical models, the models that replicate human disease, and to be able to test the drug in the lung disease microenvironment to assess potential therapies before it goes to the clinical trial. Second, we have to integrate advanced technology to find targets from human studies to streamline discovery. The preclinical models that we actively use in the lab in the pipeline are drug discovery and drug development is precision cut-lung slices, or PCLS. PCLS is an advanced ex vivo model for translational research in pulmonary disease. Briefly, I go through the protocol for you. So first, we'll start with the fresh lung isolation from human or from animal models. Then we will do the agarose feeding. We'll use low-melting agarose to inflate the lung, keep it for a while in the cold buffer to solidify the agarose. And then using the vibrotome, we'll cut it in a very thin and viable slices, put it in culture, use it with different reagent or treatment that we have to test. PCLS maintains lung structure, cell diversity, and native tissue environment. Why it matters? PCLS enables more accurate prediction of drug effects in the lung compared to standard in vitro models. It can reflect in vivo responses better than 2D models, leading to more reliable data. And also it provides insight into local drug effects on human lung tissue. Our current pipeline that we have for PCLS preparation in pulmonary section at Yale is very routinely, and we do it very active all the time. We obtain fresh human lung tissue from Yale donation system and some other sources. As I mentioned, we inflated with the low melting agarose, and then using the vibrotome, we cut it in a very thin and uniform slices, usually between 200 to 500 micrometer thickness. These slices we're gonna keep it in tissue culture, and they're gonna stay alive for multiple days, and we do multiple drug testing routinely. The standard platform for using PCLS for translational research in pulmonary disease is 3 different systems that we have. First, for dose selection and optimization, usually we use mice PCLS, which is more accessible and easier to use. For fibrosis, we'll give the mice bleomycin, or sometimes for other disease, based on the disease of our interest, we'll use different animal models. We'll isolate the lung from the mice, prepare PCLS, and test the treatment. Second model, mimic disease model. Usually we use healthy, fresh lung from human. We'll mimic the disease based on our disease of interest on the PCLS slices. We generate the PCLS, stimulate with fibrotic cocktail to produce fibrosis, or we can use different reagent, smoking, virus, bacteria, or many other things based on the disease, and then start our treatment. The third model is diseased lung explant model, which for fibrosis, usually we use IPF lungs explant from the patient. We'll prepare the PCLS and then start the treatment. In all these models, we can have a different readout, depend to the therapy and our endpoint. We can perform efficacy studies to see what is the therapeutic effect of our drug. We can do live imaging, track the structural changes of our drug in the PCLS during in treatment. We can perform functional assays, mitochondrial functions, biomarker assays, and also transcriptomic analysis. We also do a special and single-cell RNA sequencing on these slices. Now I want to walk you through 2 different cases of drug discovery and development that we have in the lab right now actively. Case 1, developing miR33 inhibitor as a novel therapy for pulmonary fibrosis. This project started from single-cell RNA sequencing data. We knew that macrophages are one of the key cellular components in the pathophysiology of IPF. Based on the single-cell RNA sequencing from IPF lung tissue that we did in our own team, we found a specific subpopulation of the cells in IPF lungs that we call them fibrotic macrophages, and they are very dominant in these IPF lungs. And we also saw that these macrophages have a very distinct signature with abnormal metabolic activities. In the same time, we knew that none of the current candidate therapies target lung macrophages in IPF. We hypothesized that targeting profibrotic macrophages and reprogramming their metabolic pathways may offer a promising therapy for pulmonary fibrosis. What is microRNA-33? miR33 is known as master regulator of mitochondrial function. It can control cellular energy status and metabolic reprogramming, especially in macrophages. It can control pathways that regulate immune response and inflammation. We started by investigating the role of miR33 in pulmonary fibrosis. and discovered that the level of this microRNA significantly increased only in the macrophage population from IPF lung tissue and bronchoalveolar lavages of the patients. By the help of our collaborators, we generated macrophage-targeted miR33 knockout mice and tested these mice in our standard mice model of lung fibrosis, which is the administration of intratracheal blomycin to the mice, which generate fibrosis in 2 to 3 weeks. Testing these mice in this mice model showed us that these mice are protected against lung fibrosis at the level of histology, gene expression, and many other indexes that we tested. How about mitochondrial homeostasis? We discovered that the absence of miR33 in macrophages of the lung of these mice improves mitochondrial homeostasis at the level of function, decrease mitochondrial damage, increase mitochondrial gene expression, and also improvement of mitochondrial structure in these mice. This finding showed us that the miR33 inhibition not only protects against lung fibrosis, it improves mitochondrial homeostasis in macrophages of these lung. As our therapeutic strategy, we designed a molecule called PNA33 to inhibit miR33 in lung macrophages. We gave this PNA33, we injected this PNA33 to the mice from different routes, IV and also intratracheal, and showed that these drug accumulates inside the macrophages. And also, when we isolated macrophages from these mice lungs and tested the microRNA 33, we realized that after one single injection of this PNA33, the level of miR33 is decreasing in macrophages at least for 5 days, stays low. So we tested our drug in mice models of lung fibrosis. We gave blomycin and treated the mice with PNA33 and showed that these mice are also protected against pulmonary fibrosis, and our drug inhibited many of the collagen gene expressions, collagen level in the lung by histology and by enzymatic assays. We also in parallel tested PNA33 in parallel with one of the FDA-approved drugs for IPF and showed that our drug blunts fibrosis more than the FDA-approved drug in these mice. So now at this stage, we had a good proof that we have a drug that working in animal model may be better even than the FDA-approved drugs. And we have numerous cell culture system testing that it gave us the hint about the mechanism action of the drug. But before moving forward, we had to test these drug in the precision cut lung slices. First, we started with mice model, PCLS from the mice. Simply, we gave blomycin to the mice, harvested the lung, made PCLS, and treated with this drug or control and harvested PCLS. The first thing that we evaluated in this PCLS slide was imaging them with the 2-photon laser microscopy. This image that you see here, all this blue coloring, it shows the collagen accumulation in the mice. And this is the mice after blomycin. So this PCLS is the fibrotic PCLS. And this one is the one that we gave the PNA33 to those PCLS. As you see, we see much less blue coloring, which it means less collagen accumulation. And also because this drug was attached to a fluorophore, so we see accumulation of this drug in the lung, in these PCLS slices, especially in macrophages. We also performed a gene expression assay from these mice PCLS and shows that our drug decreased many of the collagen and profibrotic gene expression in these mice PCLS. This was very assuring for us. So we moved to human PCLS. We used human ex vivo PCLS from IPF patients. So we got the IPF explant, isolated PCLS and treated with PNA33 and control in parallel. We also, in parallel, used 2 FDA-approved drugs to compare our drug with the other 2 drugs. And we showed that in the histology result of these PCLS slices, our drug reduces collagen accumulation in IPF more than the other 2 drugs. We also performed RNA sequencing on these PCLS slices and discovered that PNA33 reduces fibrotic gene expression, increases some of anti-fibrotic gene expression, and also alters macrophage signature in these IPF PCLS. We also performed collagen ELISA from the supernatant of these PCLS and showed that our drug decreased secretion of collagen from these IPF PCLS. After seeing this data, we convinced that we have a drug that it could be more efficient compared to the other FDA-approved drugs that already exist. So as of today, we moved forward with the drug, and we are in the middle of some of the PK, PD, and safety studies for our drug. Case 2. Developing Sobitrom, a selective thyroid hormone receptor beta agonist as a novel therapy for pulmonary fibrosis. We know that injury of alveolar epithelial type 2 cells is an early initiating event in IPF, leading to mitochondrial dysfunction and ultimately fibrosis. Our team discovered that thyroid hormone can inhibit lung fibrosis in mice by improving epithelial mitochondrial function. We also showed in that paper that T3 blunts fibrosis and improves survival in mice, and also protects alveolar epithelial cells by normalizing mitochondrial oxygen consumption and reducing mitochondrial-driven apoptosis. So T3 can be a good drug for anti-fibrosis, but simply because of the side effect and the possibility of making the patient thyrotoxicos, so we cannot give thyroid hormone to the patient. So we raised the question that could Sobitrom, a well-characterized thyromimetic small molecule, offer a safer alternative without thyrotoxic side effects for this disease? We started testing Sobitrom in animal models. So we gave this drug and control to the mice after lomycin administration. And we showed that at different levels, Sobitrom reduces pulmonary fibrosis in the mice model by improvement in body weight, by the reduction in the hydroxyproline in these mice lungs, reduction of collagen gene expression, improvement in lung physiology, and also histology changes. We also discovered that it doesn't matter how we give Sobitrom to the mice with different routes of administration, aerosolized, IP, or oral, all different routes can be protective against lung fibrosis. How about the effect? What is the effect of Sobitrom on alveolar epithelial cells? We tested these mice lungs, and we showed that Sobitrom protects alveolar epithelial cells against apoptosis, as well as normalizes mitochondrial functions in lung fibrosis at different models using in vivo and in vitro models. How about the fibroblast? We know that fibroblast is a very critical cell and has a important role in pathophysiology of fibrosis. And the cells, the fibroblast, when it goes to the fibrosis, they have abnormal mitochondrial function. In the same time, they're becoming resistant to apoptosis. We tested these mice lungs for level of apoptosis in myofibroblast, and we discovered that Sobitrom increased apoptosis in myofibroblast in lung fibrosis. After that, we moved toward IPF fibroblast. We tested the fibroblast isolated from IPF patient and shows that adding Sobitrom to these IPF fibroblasts, it improves mitochondrial functions and also increase apoptosis. At this stage, we knew that we have a drug that we were sure that is working anti-fibrosis in animal models with different routes and different models that we used. We also performed multiple mechanistic studies, identified the downstream pathways and also receptors, which I will not go through the details of our mechanistic studies here. But before moving forward, again, we had to test this drug in precision cut lung slices to make sure it works eventually in human. So first, we used the mimic diseased model that I mentioned earlier, which for fibrosis, we call it early fibrosis human model. We used healthy human lung, isolated PCLS, and treated with fibrotic cocktail, which is combination of 4 different cytokines. We add to the PCLS, and we see that fibrosis will be generated. And control cocktail in parallel and treated with Sobitrom and the control. We did gene expression, and we show that the collagen gene expression and many other genes are decreasing after adding Sobitrom in these human PCLS treated with fibrotic cocktail. Also, collagen ELISA, again, from the supernatant, shows the reduction of collagen. Histology from these PCLS also identified the reduction of fibrosis. So we had a confirmation that our drug can reverse fibrosis in fibrotic human PCLS. Then we moved to IPF lungs. We used IPF lung explant, generated PCLS, and treated with Sobitrom and control. We did gene expression, and we identified that collagen gene expression is decreasing in these IPF PCLS after Sobitrom. Also, collagen ELISA, which showed the reduction of collagen secretory in these IPF slice. And histology also changed a significant reduction of collagen accumulation in these lung slices. Even performed RNA sequencing from these IPF PCLS and confirmed the anti-fibrotic effect of Sobitrom by decreasing in many of the important pro-fibrotic genes in this IPF PCLS. And also we identified novel downstream pathways that it can help us for the future studies and maybe biomarker development. As a summary, we have a pipeline running 2 drugs in parallel, showing Sobitrom and NIR33 inhibitor. Both, they have potent anti-fibrotic effects. In vivo models, using mice models of lung fibrosis, in vitro, using primary mouse and human cell culture system. And more importantly, both these drugs in ex vivo models using human precision cut lung slices from healthy and IPF patients confirmed their anti-fibrotic effects. Both of these drugs, they improve mitochondrial homeostasis and function, one in macrophages and the other in fibroblasts and epithelial cells. And the nice thing about using PCLS, because we preserve all different cells in that slice together. So it doesn't matter what target cells your drug is working on. You have the cells in the PCLS, and if the drug is working in that drug, you can see the reduction of fibrosis or change in the pattern of the disease in these lung slices. Both of these drugs currently are in the pipeline to advance to the next step for development. Conclusion and takeaway home messages. Always in the process of drug development, choose the right model. Using relevant biological or computational models it gives us reliable results at the end. Leverage human data. Always prioritize human single-cell spatial data for clinical relevance and precise target Validate your targets early. By validating targets early, we can reduce risk and improve success rates later on in the pipeline. And most important fact here, always test the drug in human samples to ensure your findings can translate to real-world clinical use later. Thank you. So I will, thanks to all our wonderful team at Yale, also a special thank to all IPF patients, as well as all our funding, NIH, BI Discovery Award, and Blavatnik Award for Innovation at Yale University. Thank you, and I will take questions if you have any.
Wonderful. Before we do anything else, I'm just taking a quick screenshot because our company is good friends with PF Warriors. We
Nice.
every year at the ATS meeting, which by the way, our company will be attending, and so is Dr. Ahangari here as well this year in Orlando, sunny Orlando. Yes, we often are neighbors with them in the exhibit hall, so we're very proud to support your work. I actually had a couple of questions I thought of, and they're a little bit more geared towards PCLS since we are specialists in making the tissue. One of the issues for making PCLS as a model is we're concerned about viability.
Mm-hmm.
So can you speak to what the viability is for human PCLS, where it's from a healthy like a transplant or a healthy biopsy versus one that is diseased?
Mm-hmm. Yes, so the viability, it very depends to the freshness of the lung samples.
Mm-hmm.
So we always use the fresh lung samples at least in the 24 hours after recovery.
Yeah. Right.
So, and when we do the PCLS, we performed multiple viable assay during the right after generation of the PCLS and until 7 days. And the viability stays good. So the cells are live and healthy, even minimum of 7 days. At least by 7 days, I can be sure that they are good.
Oh, great. And is there like an upper limit? How long have they lasted for in terms of viability? Do you know?
So we never, in our team, we never extended after 7 days. So at some point we will do that. So they might exist, but I'm not sure yet.
Wonderful. That's great to hear because 7 days is a long time to explore research in this type of environment. Could you also tell our audience a little bit about tips and tricks for sectioning IPF or fibrotic human lung sections? Because often they're much more challenging than mouse PCLS because they're fibrotic and you might not get the agarose infusion properly. What are some tips and tricks to help us get better human PCLS?
Yeah, for human PCLS, so the homogeneous inflation and the way that we do it, it's very important. If inflation works well, and also after inflation, we have to make sure that clip everything that it doesn't leak. If there is a hole anywhere in the lung and agarose start leaking, then we lose it.
Right, it collapses.
Try to keep it tight and put it in a big container, in the buffer, in the fridge for some time to make sure it's solidified before making the core and start the cutting.
Wonderful. And the last question is inspired by the two potential therapeutic targets and medications. Where in that pipeline are you now in terms of clinical trials with humans, and or what kind of timeline can you anticipate?
So we are still in very early stages. For miR-33 inhibitor, so based on the Blavatnik award that I received from Yale, so I'm doing some safety pharmacokinetic studies and going. But for Sobitrom is still earlier. So at least we know that the discovery phase ended. So moving toward the next stage, it needs a huge amount of funding. So hopefully we can get some grants or some industrial funding to proceed.
Wonderful. We're very excited to hear about developments. We're going to keep a close check on that. So thank you so much once again for your time and your presentation today and for your discoveries.
All right. Thank you so much for having me.
Wonderful. Thank you everybody for attending as well.